Assalamu alaikum and good evening, everyone. Today's topic that we are going to debate on is with my colleague, Dr. Mustafa, is should we reserve Ocrevus or any other high efficacy drug for later lines? All our current understanding about MS is that it is an immune-mediated pathology which can lead not only to inflammation and demyelination, but also neurodegeneration of central nervous system. And if this is left untreated, it can lead to ongoing cumulative macroscopic and microscopic CNS damage. We have the availability of 23 DMT therapies with 10 different mechanisms of actions, all manipulating immune system. And we are facing increasing pressure to start early and start big. So what is escalation approach, which I'm going to discuss as our first option of MS treatment rather than having to start with high efficacy drug? By definition, escalation approach means that we start with a lower risk but lower efficacy DMT and move on to more aggressive treatment if the ongoing approach fails. The rationale is based on concerns that due to complex safety profiles of higher efficacy DMTs, they should be reserved for patients with greater risk of accumulating disability. The individuals are typically those who show higher levels of clinical or radiological MS activity. Often this approach is termed rapid escalations, which most of us are doing now, due to the need to minimize delay in therapy switching and to ensure patients do not occur any permanent disability. So why don't we start looking at our own Minactrin's 2019 guidelines for treatment of relapsing remitting MS. And some wise MS physicians have come together and actually have agreed upon that moderately or mild to moderately active disease should have the first line therapies. And if there is suboptimal response, then we should consider therapy escalation. This is also shown in the German Society of Neurology MS Treatment Guidelines 2018. And for them also, they prefer that upon failure of initial DMT, patients with mild to moderate disease should be treated with higher efficacy drug. So let's look at these MS treatment strategies. High efficacy drugs versus escalation. The emphasis is on NIDA, but is NIDA enough? Can we get there for all our patients? Should we treat more aggressively to treat disease activity that we cannot even see or measure? By starting with high efficacy drugs, gray matter lesions and brain volume loss matters, but we can't measure this in all cases as routine. So do we treat all our MS patients aggressively as one size fits all? Or we practice precision medicine with careful selection based on many factors? We know that there is a great variability in disease expression in MS. And how about prognostic factors? Who should be the ideal candidate? What about risk-benefit calculations? What about patient preferences, comorbidities, tolerability, traditional and cultural sensitivity? Let's tackle these scientific claims. Higher efficacy drugs are more effective drugs. Indeed, but we need head-to-head trials, randomized controlled trials to address this. Money matters. I'm not talking about just financial cost, but the real cost with regards to risk-benefit ratio. For every number of patients to treat, there is also a number to harm, as high efficacy drugs also carry greater safety risks. Patients do deserve the choice to choose their DMT. I totally agree. This is good clinical practice. However, such therapies are often denied for first-line use by many payers. who demand data on efficacy from randomized trials. Traditional DMTs are commonly used worldwide, so prescribers and patients might also be uncertain about the evidence supporting high-efficacy DMTs as a first-line therapy. Notably, in the real world, with more patients with comorbidities and fewer support staff, clinicians might not be poised to optimize risk mitigation strategies, thus further increasing the potential for harm. We cannot pursue precision medicine and then talk about biomarkers while arguing for uniform treatment strategy for all. The natural course of the disease in MS is unpredictable. Thus, labeling the disease at its onset is particularly challenging. My colleague Mustafa will probably tell you about many studies where low efficacy drugs are not as effective as high efficacy drugs. Indeed, but there are no head-to-head trials or randomized control trials. However, we need to look at this into more detail. And currently, two studies, one Deliver MS and Treat MS, are looking exactly into this to understand where to use high efficacy drugs. Deliver MS is currently being performed in 24 centers across UK and US. The study will show whether starting treatment with high efficacy drug for MS improves the prognosis for people with MS. Currently, it is not known that this is any better or worse than an escalating approach, where people are only given stronger treatment if they are necessary to control the disease. High efficacy drugs are uniformly dangerous? No, I'm not saying that, but assuming we know everything about MS is dangerous. So, in my opinion, and I'm sure you will all agree with me as well, that Menectrin's guidelines for the treatment of MS approach should be predict and personalize, and it should be precision medicine for MS in 2021. I hope you will agree, and thank you very much for listening.